I'm Dr. Nasser. I'm the medical director of the acute rehabilitation unit at Palmdale Hospital. Today we're going to talk with some colleagues about what is acute rehabilitation and what we have here specifically at Palmdale Regional Medical Center. So we have an acute rehabilitation department, and it's kind of like a hospital within a hospital. We're a very unique center in that we offer specialized rehabilitation that's focused on particular injuries, and we have some very specialized equipment here, and we work as a team. What does that mean, working as a team? It means we involve physical and occupational therapy, we have specialized rehabilitative nursing, we involve dietitians, and often other physician consultations. Acute rehabilitation is very special in the sense that patients who come to acute rehabilitation have active medical problems that need supervision, but also require multiple therapies like physical therapy or occupational therapy or speech therapy, and oftentimes all of those therapies in combined. So some of the diagnoses that we see are brain injuries, spinal cord injuries, strokes, fractures. We see a lot of patients after they've had trauma or sometimes after joint replacements, but we're not limited to those. We see many patients who just have a host of multiple medical problems that have become very weak, can't care for themselves, can't get around the community or around their homes. And it's a very special unit because we're unique. There isn't a unit like this in the Antelope Valley other than what we have. No one has the equipment that we have. We've really gone to great lengths to get some very specialized equipment for these problems, for these disorders, and to help these people. Furthermore, we've gone to some great lengths to hire some very fantastic people that work in our team that help patients who come to acute rehabilitation transition to home. So ultimately, that's what acute rehabilitation is. It's a transition to home for people who have had major medical problems or have become deteriorated and can't care for themselves. And the way that we do it here, by involving the family, involving multiple specialties, and involving an entire team, we have found to be not only per protocol, but extremely effective. And we've been able to help quite a few people get home and get back to the way they were prior to their trauma or their illness or whatever has occurred. And we're actually very proud of it because of the success that we've had. I'm very happy as the medical director to have such a very strong team, especially some of the individuals sitting with me today. Dr. Pena, our associate medical director, Dr. Nestor, our social worker, discharge planner, and our chief administrator, Veronica. And so we're all going to kind of talk a little bit, and I think Dr. Pena is going to tell us a little bit more about acute rehab and the kinds of patients who come to our department.
Yeah, so it's exciting to get to work with some patients here on our unit. In particular, there's typically what we call a CMS-13, or a group of diagnoses that we work with routinely. Diagnoses such as spinal cord injury, stroke, traumatic brain injury, hip fractures, major multiple trauma, just to name a few. These are types of diagnoses that we as rehab physicians know how to work alongside a patient on an acute rehabilitation unit, but also how to lead a team of therapists from a multidisciplinary standpoint, dealing and working closely with patients during their rehabilitative course. But oftentimes folks come just after an acute hospitalization in which they find themselves with a clear functional deficit. We as the rehab physicians have an opportunity to evaluate patients prior to coming to our rehab unit. We utilize the help from the rehabilitation team, also including a liaison, typically either a clinical or a liaison who will be an extension of our unit out beyond the unit. Again, these diagnoses oftentimes come into play, but even orthopedic trauma that may not fall into certain categories that are the quote-unquote bread and butter of acute rehab. So things like ankle fracture or mid-shaft femur fractures, anything that essentially has a functional setback for a patient. Patients obviously have to also have the capacity to work pretty intensely on a rehab unit, especially an inpatient unit where the expectations are a little bit more aggressive. However, programs are tailored to each individual patient, which is another fantastic part about acute rehab. It's very specialized. It's not a cookie cutter type of approach to rehabilitation by any means. And so some folks may require shorter sessions, but more spread out throughout the day. And those are things that we're always taking into consideration when patients are on our rehabilitation unit.
There are different levels of rehabilitation. So there's acute rehabilitation and sub-acute rehabilitation, and the primary difference between the two is the intensity of the therapy. So in acute rehabilitation, patients receive about 3 hours of therapy per day, about 5 to 7 days per week. In sub-acute rehabilitation, patients receive about 30 minutes of therapy 3 to 5 times per week. So the patients that come to acute rehabilitation are patients who can tolerate multidisciplinary therapy. They're strong enough, they're able to participate in those therapies, and we've also seen prior to them coming that they've demonstrated a benefit of some sort from that therapy. Contrast that to subacute rehabilitation. There are a lot of therapies that are done right at the bedside while the patient's in bed, especially speech therapy or some of the occupational therapy, where they're really working on self-care or grooming or activities in the bathroom like showering and hygiene, etc. The other component to this is the medical component. So patients who come to acute rehabilitation have medical conditions that require continued physician oversight or supervision. And the patients who go to subacute rehabilitation are a little more stable and they don't necessarily need a physician to see them every day. An example of this is a patient who perhaps have had a stroke. When a patient's had a stroke, sometimes it could be from like a heart arrhythmia or some other type of issue. And once they've stabilized in the acute hospital and they come over to the rehabilitation center, they will begin this aggressive exercise. In the context of that aggressive exercise, the patients are at risk for having worsening that medical problem that caused the stroke or having worsening some of their other medical problems. Oftentimes, a patient like I'm describing that's had a stroke also has COPD or some lung or heart or other type of problem that requires a physician to be seeing them regularly. So the other very special thing about our unit is that the doctors, Dr. Pena and myself, we're seeing these patients every day. We're seeing them with consistency. And because we're seeing them every day, we're very involved with the rehabilitative team. The integration of the team is what I find absolutely fantastic. So for example, if a patient is working on their bowel or their bladder program, the patient would be working directly and simultaneously with a nurse and an occupational therapist, and they work together. And then once a week, the physician and this entire team, we all sit at a big table like Thanksgiving and we discuss these patients and we go over every single detail of their family life, how they're walking, how they're caring for themselves, what are their medical conditions. And as a team, we have this huge collaboration on how many days we believe the patient needs to be in rehab, what types of adjustments we need to make to their therapies or their medications or their diet or whatever it's going to be. There is no other setting in any hospital, any nursing home, anywhere else where that type of meticulous attention to a patient's daily needs and life is paid. And so that's really exciting, especially as a physician. As a physician, you know, we're moving very fast. We have a lot of patients to see. In this context of our current medical environment, there's so much going on. And the opportunity to stop and sit down and really have a great conversation with a discharge planner, an administrator, a nurse, a speech therapist, a dietitian, get all of this really good information from live people in front of me, not a chart, and get their opinions. These are great people who went to school for many, many years. They're very educated. So to get their opinions and get this information helps us as physicians just really sharpen what we're doing and optimize their care, not wasting any moment, any time, and making sure that every minute that they're in that rehab unit, they're actually getting absolutely what they need. But we take it to the next level by having this detailed level of care and this detailed attention to all of the patient's needs. And you know, with that, I'll leave it to Veronica or Nestor to kind of chime in on some of that.
I'm Nestor. I'm the clinical care coordinator here. I like what Dr. Nasser was talking about. Our IDT approach is one of my favorite days here in rehab. We strategize what's going on with the patient and make it patient-centered. How can we get this patient home safely, back to their environment, back to doing the things they were normally doing? And if we have to adjust things, we do it. The physician will say a patient's blood pressure might be hindering his, ability to perform therapy. So we stabilize the blood pressure, and we notice the differences that makes. Something so small makes a big difference. So we get the patient their DME needs for home, make sure they have what they're going to need to be successful at home. We like to link them to community resources. From here, we love to get patients out to our outpatient clinic for that ongoing rehab that they're going to need, because it doesn't stop here. Our rehab is so short but so crucial in order to get the patient home.
Nestor, can you talk a little bit about what we do and the importance of involving the family and how that really transitions to what they're doing at home, because the families are going to be one taking care of them when they leave.
Yeah, one of the biggest fear is for the patient is, what am I going to do with my new inability to do a certain task? Something so minimal like going to the bathroom is so important, and that's so important for the patient and the family, the caregiver, to be there for and learn how to do it with this, possibly with this new disability this patient's going to have. We encourage family education. We encourage being here with your loved one, because it's gonna bring out the most out of that patient in order to be successful.
Yeah, we love having the families come and actually participate in therapy. You know, when the patients go home, they're going home with mom, dad, wife, husband, or whatever it's going to be. The more involved that the families are here with when therapies come by or what the nurses are doing, the better. And again, I think that also makes it something that's very unique to our unit is the family involvement. I mean, Nestor meets with all the families. We identify different things, and if we identify a family or a situation where patients really need extra care, then we will all meet with that family, with the family members. Education is really, really big, especially in healthcare. And the more we educate these families on how to care for their loved one at home and what to look for as a potential problem, the more successful that they're going to be, when they get home and when they're in that environment. We even have an apartment. We have a little suite on the side here that's a makeshift apartment with a bed and a couch that's completely different than a hospital room, and patients can stay the night in there with their families. They can practice getting in and out of a normal bed. They can practice getting in and out of a normal chair. We have a kitchen where they practice making meals and doing things. And that also lends to a really great community that we have in our rehab unit. We have patients who will make meals for the other patients. We do a lot of community activities here with the patients, whether it's games or different things with occupational therapy. So, we're creating kind of a home environment for them. And again, that's what acute rehabilitation really is, a transition to home.
What you can expect at the Rehabilitation Institute during your stay is that your routine will be very different from what it was while you were in the hospital. You will be in your own clothes, you'll be wearing shoes, you will be out of bed more often, you will be more active. You can enjoy your meals in the dining room, and I think that's very important for the patients to understand that we have a very magical place here. It's very different. Within the first 24 hours of admission, you will meet your entire team. You will meet your clinical care coordinator, you will meet your RN, you will meet your physician, and then of course you will meet your therapist that will evaluate you and set goals with you and create an individualized plan of care that we had talked about, and then the rehab begins. We want to replicate as much as we can those activities that you'll be doing so that you're successful when you go home and as independent as we can get you.
So, one of the things that about Veronica that's very special for us here is we're fortunate enough that she has a wealth of experience in nursing from the rehabilitation standpoint. So having an administrator with that type of experience really, really helps us to sharpen things. We do a lot of educational activities with our nurses, and we involve a lot of people. I've been doing acute rehabilitation for 21 years, and I often will lean on my team because they have more experience than me or more knowledge, and they've been through quite a bit. So it's good to have a strong group here, and collectively we've been doing a real good job of taking care of patients.
Basically saying, or even directly to us as a physicians, like, you have such great staff here. And I always like to remind them I'm really just one piece or one cog in this giant machine that's working together for each individual patient. Very much a team approach to rehabilitation is why I love this field so much. I grew up playing sports my entire life, and being on a team I think is very, very important. Leaning on one another. Things can get difficult just from the standpoint of patient care. Obviously stopping and taking into consideration how difficult it must be for these patients who've come from complete independence and have suddenly found themselves with major impairments and fear about going home, fear about not being able to take care of themselves as they once had. And so always kind of taking a step back and a refreshing thought to think that squad, an entire team of people are here, each with their own individual specialties and backgrounds and training, and all of this knowledge being kind of presented for patients and families to benefit from as they transition back home. I think transition is such a key word here. We really do try to set this environment up so that step out of the door means it's just that much closer to being back home and back to some normalcy. So it's a very special thing to be a part of a team like that.
We're all very scientific. We're all very learned. We've been to college and graduate school and medical school, and we're all very smart people. But we're not so robotic in that intellect that we've lost our human touch. we see some really heart-wrenching things. There are tears. It is sad. This is a difficult job at times. And what I love about it is it's an area of medicine that we have become passionate about because of that intermixing of our intellect and our human side. There's a lot of real just love and care that goes on. We pat each other on the back and we give hugs and we really care because it's hard. It's if I'm being real with you, it's hard to take care of people who have had such devastating things happen to their life. While this may be 2 or 3 weeks of my life, which is a blink and I don't remember it, this is a significant 2 or 3 weeks of their life that they will never forget, the things that we say to them, the activities, the things that we were able to be part of in their lives. And so that is such a, monumental task. It takes a whole team. It takes a village to really help these people get back there. The best doctor in the world couldn't do it without a team of people, and we're all talking all the time, and everybody's input is important, and everybody cares about the patients. And I could tell you this with an honest heart, that if I had an injury, I would want to come to this unit. And I've thought that a few times, geez, would I want my staff taking care of me? And I really, really would. I can't be more sincere about that. If something happened to me, I would want to come to this unit. I would want these people taking care of me. And it's because I really believe everybody cares, and we care a lot. And when we have that type of environment, we have that type of enthusiasm, and we apply our knowledge and experience, it becomes very special.
And the hardest part is to tell a patient, we've graduated the program, it's time that we're going to get you home. And they love it so much here that they don't want to go home. They want to stay here. Right. They love the unit, they love the doctors, they love the administrator. So it's a great place to work at. It
continues on. We have a fantastic outpatient program that we really love to transition patients to. Dr. Pena and I see the patients after they discharge in our office. We absolutely refer them to that program. And the outpatient group is equally enthusiastic and exciting and passionate about what they do. We go over scores. We go over every week, and patient satisfaction. And I'm not going to lie to you and tell you that we get 100% satisfaction. I don't know who does, but we get in the high 90s. Yeah. And we do, and we get a lot of people who are very happy. It's a great place to work. After being in practice, and out of training for over 20 years, a lot of my colleagues are burned out. We're not. We're happy to be here. We love doing it. So it's a great opportunity. If a patient could come here, we want to take care of them. I think that there's a lot that goes on that we haven't mentioned, and I think some of the very special people on our unit that give patients special attention are the nurses. These nurses are worth their weight in gold. They are so helpful to us. Having a strong nursing team that understands rehabilitative needs and understands the patients has been a really good asset to us and has helped us to help these patients. And we're committed to these patients and seeing things through to get them home, even if their medical conditions, make it such that they have to leave the unit and come back. And that is really a thing that we can only do if we have a strong administration, which we do, and if we have strong nursing. And so it's been really a big part of what we do, having a strong nursing program to help us identify these patients and care for them.
We are the only unit in the Antelope Valley that can have dialysis here in our facility versus going to a different setting, and then you have to be transferred to a local dialysis center. So that's another big part of rehab here is our dialysis availability.
And with regards to dialysis, this is another area where it requires us to be very meticulous. So when you got a patient with dialysis, it's almost kind of like when you see the lady with the spinning plates, and you got all these things happening with the patient, all these medical conditions. Well, I got to squeeze in 3 hours of therapy. I got to squeeze in dialysis. I got to squeeze in a bladder program or bowel program and all these different things, and nursing and pain management. These patients are busy all day long. Something's happening all day long. And then with dialysis, patients are often really fatigued afterwards. So you never want to schedule therapy after dialysis. And so I don't know who makes our schedules, but I feel bad for them. A lot of the talent comes in our administration and our therapists, and just really coordinating all this stuff every day, And when I see patients on rounds, I would say, only a handful of my patients are in bed. Having that, jovial, lighthearted interaction with the patient sets the tone and the climate, and the culture of our rehab unit. And they don't feel like they're just, oh my gosh, I had a stroke, I'm here to die. No, we're here to get you back. We're here to get you back to where you were.
We have a simulated car, and so that's something that the patients can do. We don't have to take them out in the rain or the heat or the wind. We do have a Vector, which is our device. Yeah.
We have the virtual reality trainer. Yeah.
We have the new Alter G.
We have the new Alter G. Yeah. The Alter G and the Vector basically de-weight a person, and they're allowed to walk on their legs without the weight of their body. So if a person is partially weak on their legs, it's really cool. They have a harness and everything, and the Alter G, you can actually run on a treadmill without the weight being on your legs. So it's cool, and it's great in this setting, but it's also great in the outpatient setting for people who have sports injuries and back pain and things like that.
Especially for some of our younger patients. We bring patients all ages, they're in their 20s, they're in their 30s, they're in their 90s. So an Alter G would be good for someone who's athletic.
Absolutely.
That maybe had a ankle fracture, and,
right.
and we can get that weight off of their leg.
One thing we did not mention that I think is really cool is, and you're gonna laugh at this, but the furniture's nice. The furniture's really nice. The rooms are really nice. They're very spacious for when family members come. We have 27 beds, which is a nice sized unit to service the community, and they're all private rooms, and a lot of the rooms have a view.
The ADL room is my favorite.
Yeah.
At one time we had a husband and a wife here. Both were patients. Both of them had medical needs. They were both hospitalized, simultaneously, and we brought both patients here. And the ADL room was perfect. Getting them in that home environment with a queen size bed that they have at home is something that's nice. COVID, we adapted to it with the whole pandemic. Veronica, maybe you can enlighten us a little bit more about how we adapted. We take patients on isolation. We can accommodate to that. What are the things that we did as a group that helped us get through the pandemic and moving forward?
Well, we did follow all of the CDC and LA County guidelines. We waited until the patient had reached a certain point in their quarantine so that we could bring them in. If they required isolation for a few days, we were able to do that. We made sure that we kept all of our patients and all of our staff safe. We utilize masking and keep social distancing, particularly in the gym and in the dining or the group areas.
As you can imagine, with a situation like COVID and a pandemic, we did not neglect these patients' rehabilitative needs because of COVID. We stayed open, and we stayed busy, and we stayed diligent, and we still followed the guidelines offered to us by the LA County Department of Public Health. It was a very challenging time. We won't minimize that, but our team, I was impressed. We pulled through with really, really flying colors. We were able to keep our numbers strong and really take care of the patients, but it was tough. Have all the patients in the gym. They interact. No, it had to be. A lot of the therapies had to be limited to the room. A lot of the. I remember the day Veronica said, "Okay, now we can have the patients eating in the dining room," and we were all excited about that again because the rehab unit has a vibe. And when you walk on this unit, there's patients in the dining room, they're in the hallway, they're in wheelchairs, they're moving around. It's not like the irregular floor where all the patients are in the rooms. And during the pandemic, we had really lost that vibe, we had lost that energy, and we had to kind of work double time to get that energy back, to get the vibe back, to get the patients into really feeling like, okay, there isn't a pandemic out there. You kind of want to, not like cover it, but you have to come in with enthusiasm. The people are dying left and right, and you got to come in here with a smile on your face and tell them you're going to be okay. And that was challenging, especially with the practical things that were in place. But we pulled through. I hope we don't have to do it again, but we pulled through. It was good. We have patients in our practice that had brain injuries 20 years ago. They're still coming to see us. Spinal cord injuries 15 years ago, still coming to see us, and we're seeing them on a regular basis. That's something you have forever. So equipping these patients with the intellect, the resources, the ability, and their families to live with that condition for the long term, I think that's when we really hit the home run. Because you'd have the patient would come back a year after their discharge, 2 years after their discharge, 3 years after, and you would come and we'd see all these people and you'd be like, oh my gosh, look at how incredible you look. You're actually, last time I saw you, you were in a wheelchair and now you're walking. And they bring their families in and they tell us about the successes that they have in their lives and how they're doing after they've left rehabilitation. I tell you, that's worth more than anybody could pay me. You know, just to see those people come back and just to know that you were part of their life in that moment, in that time, and what they did. It's just fantastic. It's just it's like you can't be part of anything more exciting.